Everyone. Welcome to our Thursday morning grand rounds for the Department of Medicine. And today it's my pleasure to introduce our speaker, Dr. Shahab Ghafghazi, who many of you know. He's going to give a very illuminating talk on a problem we see on a daily basis, namely, when do we revascularize in coronary artery disease? And I hope that at the end of it, you realize how complex this topic is and how much we still don't definitively know about this. So I'm really looking forward to this talk, and you'll realize it's not as simple as if you see a stenosis, you fix it, the so-called oculostenotic reflex. So Dr. G is an associate professor in our division of cardiology. He's also the program director for general cardiology fellowship, which has grown stronger and larger due to his dedication and hard work with our fellows. He received his MD from Isfahan Medical School in Iran in 2001, and then did an MRCP in the UK before moving to the US to do a second medicine residency at UT Southwestern in Dallas. That's how much he loves internal medicine. He then moved to Louisville in 2011 for his cardiology fellowship and has been a loyal and proud member of the cardinal community since that time. His clinical interests are in acute and critical care cardiology. He has an extensive portfolio of research trials that he's conducting here. He's the highest enroller worldwide in a trial called MINT, which is looking at the effect of blood transfusions to keep hemoglobin above 10 in acute coronary syndromes. He's doing many other trials such as MPACT, SOS, AMI, and he's the PI on the critical care cardiology trial network, where we take a snapshot of all our acute care patients in the CCU at Jewish and send that data to Boston, where the central repository is. He's also worked very closely with people at the Speed School of Bioengineering, really a terrific model of collaboration, and he may talk a little bit on flow dynamics and coronary stenosis. He's received the Best Teacher Award 2 years from our fellows in 2018 and 2021, and from the medical residents in 2021. So we want to thank him for his dedication to education. And more importantly, he's a really astute scholar and a gentleman, and he really shepherded our fellows with a steadying hand during the COVID pandemic. And we appreciate his work during that time. So with that, Dr. Ghafghazi, the floor is yours. I look forward to this talk.
Thank you very much, Dr. Kaura. I'm not sure the person you were talking about was me, but I'm going to get started. Okay, so I have given, I think this is my third talk about coronary vascularization. So I'm thinking some of you will be sick of this by the end of this, but hopefully I'll share some new information and maybe dive a little bit deeper and talk about some of the new data that has been generated in cardiology space that may be applicable to your practices as coronary disease, such a common disease, and you come across these patients all the time. Here are my disclosures. So here's a vignette, very common, I guess, scenario for cardiac patients, 68-year-old patient with hypertension, diabetes, hyperlipidemia, and who presents with a month history of chest pain, exertional chest pain. Exam, ECG, and X-ray are normal. Patient undergoes a stress test with SPECT, does about 6 minutes on Bruce protocol, and stops due to chest pain. The SPECT imaging shows moderate to large size ischemia involving these territories that you can see, and coronary angiography shows obstructive three-vessel disease. So diabetic, male, hypertension, other risk factors, three-vessel disease, and what to do with that. So let's just go over the data and dive a little bit deeper about what this is all about and how we approach these patients. So here's a typical angiogram for a patient like that. So this is the right coronary artery, as you can see very easily, multiple blockages, in fact, and here, this is that right coronary artery that's getting collaterals from the left side. This is the left circumflex with obtuse marginal with severe stenosis, and here's the LAD with essentially extremely severe 90% stenosis, as you can see here. So classic three-vessel disease. And again, hypothetically, philosophy of medicine is to improve life or survival and to improve quality of life, either make people live longer or live with better quality. And you already know this, ischemia-driven revascularization is not supported by current evidence. But let's dive deeper into this. Now, this is some of this data I presented before, so I'm going to be very fast, maybe about 10 to 15 minutes, and then talk about some of these nuances and newer issues that have transpired since a couple of years ago that I talked on this topic. So we start with COURAGE trial in 2007, the first really major trial in this space that said, okay, you know, we're essentially revascularizing patients with stable coronary disease exponentially. Is this the right thing to do? And it was about PCI only, not CABG. So as you can see, they got about 1,300 patients with stable ischemic disease, and they were randomized to PCI plus optimal medical therapy versus optimal medical therapy alone. And the primary endpoint was death or MI. And as you all know, COURAGE trial with essentially follow-up up to 7 years and a mean follow-up of 3.4 years, a median follow-up of 3.4 years, didn't really show any benefit. So when COURAGE was essentially extended in terms of follow-up, and at this stage, observationally, patients were followed up to 12 years, the outcome was not different. As you can see, the p-value here, see if I can use this laser pointer, the p-value of 0.53, which essentially doesn't show any difference between the two treatment strategies. Obviously, at this stage, this is observational, but it suggests that there's no legacy effect that would essentially show itself with extended follow-up. So the implication of COURAGE was that PCI can be deferred safely in patients who had stable disease, and even if the stable disease is extensive. So 30% of patients in COURAGE trial had 3-vessel disease, and another 30% had 2-vessel disease. And then in sort of typical cardiology cohort these days, 30% of patients had diabetes. So a lot of diabetes and a lot of multi-vessel disease. And based on COURAGE, it looks like we're able to essentially treat these patients medically. In fact, 2/3 of the patients did not get revascularization during long-term follow-up. At the same time, around the same time, COURAGE was published in 2007. 2009, we had BERRY 2D, which had, with a different approach, looked at about 2,400 patients with diabetes type 2, so even higher risk with ischemic, stable ischemic disease. And they were essentially randomized to revascularization plus optimal medical therapy or optimal medical therapy alone. And the primary endpoint was all-cause death only, which is, you know, if you have your studies are powered in general, this is probably the best primary endpoint ever. If you had enough money, maybe this would have been in a lot of trials, maybe the sole primary endpoint, and the others be part of secondary endpoints. So BERRY 2D had 2 strata, just to point out, had CABG stratum, about 700 patients, and PCI stratum, about another 1,600 patients. And the randomization was happened inside those strata. So OMT versus CABG plus OMT, and OMT versus PCI plus OMT. And as you can see, no difference, essentially a follow-up up to 5 years. And when they looked at the strata separately, in terms of death, there was no difference between revascularization, whether with PCI or with CABG, compared to optimal medical therapy. In 2012, the Freedom trial was published, and Freedom looked at diabetic population again. However, this time the question was, should we do CABG or should we do PCI? And you may ask yourself, well, we already have seen courage with 30% diabetic patients and 3-vessel disease. And of course, you've seen Berry 2D. So why on earth would you not have a third arm here, having a medical therapy, PCI plus medical therapy, and CABG plus medical therapy? And so I asked that question from this gentleman, Michael Farkul, who was the primary author of the main paper of Freedom trial. And the answer was actually very interesting. So he said that at the time when they designed the trial, it was actually pre-Courage publication. So they designed the trial around 2005. And at the time, the thought process was revascularization is a given. What we have to determine is what is the best way of revascularization. Anyways, about 1,900 patients with diabetes type 2, multi-vessel disease. So PCI with drug-eluting stents versus CABG, as I said, no optimal medical therapy alone group. And the endpoint, primary endpoint, was composite of death, MI, and stroke. Here's, you see how the randomization trial design happened. And the outcome was death, stroke, MI again, not just death alone or MI alone, all the three of them, but you can see a big difference between the two groups. And in fact, when they looked at individual items, so MI alone, you can see the difference. And mortality alone, again, you can see the difference in a follow-up up to 5 years. So I want everybody to pay attention to the MI one and have that in mind, at least in multi-vessel patient, coronary disease patients with diabetes. CABG reduces the risk of MI alone. So have that in mind, and we'll talk about this a bit more in future. Extended follow-up of Freedom up to 8 years showed that essentially, now by this time, remember with any extended follow-up, there's no randomization anymore. So what you're looking at is essentially, is there a legacy effect? So what the benefit that you see, if you saw the benefit in this case, did that continue, even though by the time the result of Freedom was published, probably a lot of those patients on the PCI arm, if they had recurrent disease, probably were crossed over to CABG. So, but nonetheless, you can see the legacy effect, and in fact, the graphs continue to diverge up until this publication in 2019. So now, why did we have ischemia trial done despite essentially having all of this data? That was done because of these reasons. One of the reasons was that there was a lot of crossover in Courage and Berry 2D. As you can see, about 33% in Courage and Berry 2D, 42% from the medical therapy arm to revascularization arm. And whenever you are essentially crossing patients from the control group to the intervention group, you are diluting the effect of your intervention, because you're going to analyze the data on an intention to treat basis. So that's one of the reasons. The other one was in the two major landmark trials, we used a lot of drug-eluting stent, 97% in Courage, 66% in Berry 2D. The third one was with these trials, you already knew the result of, or you knew patient's anatomy. And a lot of physicians felt uncomfortable allowing these patients to get randomized in the trial. And so if you don't know the anatomy, maybe you don't have that sort of referral or selection bias. And finally, that some of the patients were not necessarily highest risk patients that were enrolled. Now, at this item here, that observational studies suggested that you need at least 10% ischemia to see that revascularization essentially improves cardiac death. So y-axis here is cardiac death. And based on this, this is just one of several observational studies. It looked like you need a minimum of 10% of myocardium at risk to be able to show the benefit. Now, with all of that in mind, ischemia was done. They needed a large trial. So 5,200 patients. Ischemia is the most expensive randomized trial that NIH has ever funded. $100 million so far has been spent on ischemia. Now we are in a extent part of the study, so it's not more expensive anymore, but for the actual trial, that's how much money was spent. So 5,200 patients with moderate to severe ischemia were randomized to optimal initial invasive strategy and optimal medical therapy, or just optimal medical therapy alone. What happened here was you found ischemia on a stress test, and you essentially decided not to do a coronary angiography. To make sure that these patients didn't have left main disease, they did go ahead and do a CT scan, as you can see over here, which the investigators were blinded to. So went to a core lab to make sure that if patient has left main disease, that they exclude them, because this was not a study for left main disease. And sometimes you do have ischemia, but you don't really have that much coronary, epicardial coronary disease, so to speak. One major item that is poorly defined to this day is cardiac syndrome X, or microvascular disease. So 73% of these patients essentially went through CT scan. There are reasons patients were not, sent through CT scan. For example, if the GFR was less than 60, they decided to avoid that. And of course, if somebody had known anatomy from before, they were not excluded, even though the idea was to make sure that the investigators don't know about the anatomy, but they wanted to be able to enroll as many patients as they can. So they allowed those patients in this study, but those patients didn't need to have a CT scan done. And of course, they were randomized to conservative strategy versus invasive strategy. And in conservative arm, if you essentially continue to have problems or symptoms, you were allowed at the discretion of the primary physician cardiologist to cross over to essentially get a heart cath done and figure out what's going on and go from there. So all of this was done to exclude low-risk patients, as we said. So patients had to have moderate to severe ischemia to reduce referral bias. That's why the investigators did not know the anatomy. The idea was to do sort of modern practice of cardiology, have a heart team, use as many drug-eluting stents, offer as much CABG as we can, given what we know about, from Freedom trial and syntax that I didn't talk about, which was essentially, again, looking at CABG versus PCI in patients with 3 vessel disease, and was very much similar to Freedom, showed that CABG is better. And of course, use some more advanced imaging technology like fractional flow reserve and intravascular ultrasound and so on and so forth. Of course, they wanted to make sure they had a big enough of a population, and they managed to do that with 5,200 patients. And as you can see, so these patients got blinded CTE, and if the anatomy was legible, they were randomized. If the anatomy was not, for example, they didn't have, yes, they had ischemia, but CT didn't show any significant epicardial disease, or showed left main disease, they essentially screen failed. And that 25.6% who did not get CT for one reason or another, essentially were allowed to get randomized just directly. And on invasive side, they got a cap, and the decision was made where to go from there. And on conservative side, they started with medical therapy. So 3.5 years essentially average follow-up, and the endpoint was death, MI, resuscitated cardiac arrest, hospitalization for unstable angina, or heart failure. And you can see some key secondary endpoints here. So I want to just draw everybody's attention to sort of classic cardiology cohort in these days, in modern day, in any essentially cardiology floor or service. You'll see that about 1 out of 4 are female, about 70% have hypertension, and up to 40% have diabetes. I don't have, in fact, smoking here, but on ischemia, about 12% of patients were current smokers, and another 40% were former smokers. So still significant, history or past history, I guess, of smoking. And of course, angina. These were, as you can see, the idea was to get moderate to severe ischemia. So a lot of these patients really did have angina, as you can see, 90% over here. They managed to get even a more severe cohort of patients with coronary disease. So Courage trial had about 30% three vessel disease versus almost 45% here. Courage had about 30% two vessel disease, and you can see about 30% two vessel disease. So together, multi-vessel disease was 75% of patients, essentially, out of the 5,200 patients that we can see. Now, proximal LAD, as you all know, you've heard of the widowmaker. That's when proximal LAD gets involved in an MI, and that was up to 50%, 46% or 47% of patients with in Courage had proximal LAD involvement. About 74% got PCI, 26% got CABG, 20% had no revascularization. So remember that these were, they did have about 26% of patients who ended up in this study without getting that CT scan. And so when those patients were CAT, some of them, about 2/3 out of that, 20%, had insignificant disease on angiogram. So despite having ischemia, they didn't have significant coronary disease. Sometimes the CT may have been red in a way, maybe, although CT was red in the core lab, so that's less likely. And of course, 1/3 had such extensive disease that essentially were not suitable for any form of revascularization. So that's why not 100% on the invasive arm, but about 80% essentially underwent a revascularization. And this is the primary outcome. And there is this famous inflection point here in favor of invasive strategy, although statistically speaking, there was no difference at the end of this follow-up, about up to 5 years, 3.4 years median of the primary outcome. Although, as I said, we saw this inflection point, and we'll talk about it a little bit more. As you can see, 15% adverse outcome versus 13%, but the p-value was 0.34 with confidence interval essentially on both sides of 1, which shows insignificance. Now, when you look at all-cause death, essentially superimposed graphs, as you can see here. And with MI, that's very similar inflection point. And so this explains where that inflection point in that primary outcome comes from. It looks like it comes from MI. So now let's dive a little bit deeper into this MI issue and see what exactly this is all about. So when they separated the MIs and looked at procedural MI. So procedural MI is essentially an MI that happens in the first 48 hours after revascularization. If it's post-PCI, it's called type 4A. And if it's post-CABG, it's called type 5 MI. There's a universal definition of MI from type 1 to type 5. And so these are procedural MIs. And as you can see, and it makes sense, it happens more in the group with invasive strategy, right? Now, of course, why do you have it in conservative group? Well, some of these patients, again, cross over for one reason or another to a revascularization. And so that's why you see that also in conservative arm. But you have more procedural MI in the group that was treated invasively. On the other hand, what's interesting is when you look at the spontaneous MIs, you have more spontaneous MIs in conservative group. And in fact, the graphs essentially continue to diverge here when the trial ends. Now, they published an ancillary paper. They must have published so far about 30 papers from ischemia. And they actually gave us the numbers. So here's the numbers. So type 1 MI is essentially the classic plaque rupture / erosion MI that we treat with most of the time, PCI, right? So type 1 MI in the invasive group happened 75 patients versus 147 patients in conservative group. So that's a difference of 72 MIs in a matter of a median of 3.4 years in 5,200 patients, right? Now, if you look at procedural MI. So 4A is the one that we said happens that first 48 hours, 26 versus 4. And then type 4B is the dreaded stent thrombosis, which is anytime after the first 48 hours, all the way to a few years. If you come in with a thrombosis in a previously placed stent, this is called stent thrombosis. And so you do see that more often in patients with invasive strategy, as makes sense, compared to patients with conservative strategy. So this is that 20-some% of patients that gradually crossed over in the course of the study to invasive treatment. So it looks like for, now if we sort of put those type 4As aside, so peri-procedural MIs, they tend to be milder in the sense that in the first 48 hours you are in the hospital. So these MIs are caught earlier and are treated more effectively because you're essentially sitting in the hospital under the physician's nose. Whereas to 4B, you're at home, the same as most of these type 1 MIs. So stent thrombosis tends to be ends up being a nasty sort of acute myocardial infarction. So you have to pay a little bit of a higher price, but then in return, you end up getting less type 1 MIs. Now, does this matter? So here's essentially the same study that looked at the relationship between all-cause death and cardiovascular death with MI. So the question was, are these MIs associated with mortality? And as you can see, at least with all-cause, the 4A and 5, the procedural ones, they cross 1. So they're not statistically significant, even though numerically you see a hazard ratio of 2.1. But then look at the 4B. Now 4C, they really only had like five or six patients with 4C. So you can ignore that. 4C is stent restenosis. It's a sort of a stable disease, really not a, it doesn't behave like a plaque rupture. And it is much more benign than 4B. 4B is the stent thrombosis, the scary stent thrombosis. And of course, type 1 MI is the classic MI. And you can see both of them are associated with adverse outcomes. Stent thrombosis tend to be very nasty. So his hazard ratio is 4 versus 2.4 for type 1 MI. And you see very much similar picture in cardiovascular death between type 4, type 1, type 4. Although with cardiovascular death, you do see that 4A and 5 are also not so fun to have. Although, when you go with all-cause death, which is the best of heart outcomes, you don't quite see that. Okay, so what we're saying is you're having, even though the primary outcome is no different, mortality is no different, you're having less MIs, and MIs cause death. So how is that possible? So if I'm having more MI on the conservative arm, and these MIs are associated with death, I should see more all-cause mortality, right? So maybe it will take us a little bit longer to see that. So here's the ischemia extent. So this actually was just presented in AHA this year, and is online only now available in circulation. So ischemia extent was essentially observational follow-up of patients who were enrolled in ischemia, and they were able to keep about 4,800 patients in the ischemia extent and follow-up with their outcomes. Now, the only outcome they were able to follow up was death, but of course they tried to sort of adjudicate different forms of death. So now let's dive deeper here and see. All right, so with more MIs, we were not seeing more death during the up to 5 years. And now we have up to 8 years, median about 5.2 years. Do we see any difference? So here's the all-cause death, and you can see the graphs are still superimposed. But then when you look at cardiovascular death, the graphs are in favor of invasive strategy. So red is invasive and blue is conservative. But it looks like for gaining a bit of advantage in cardiovascular death, you are giving up some in non-cardiovascular death, so that your overall all-cause mortality is null. So how do we interpret that? There are a lot of things that have been said, but the bottom line is, it doesn't matter how you die. What matters is to not die. And if you die and you call it cardiovascular, non-cardiovascular, it just does not matter. There are a lot of explanations for that people have come up with. The adjudications here were done essentially by looking at, in some countries, medical records. In other countries, for example, in the US, by the patient had were reconsented after at the end of the study for the extended follow-up, but they did not have access to medical records. So they looked at the National Death Register, and they had defined a way of defining cardiovascular versus all-cause death. And when you go over that and review that, at least the question I ask myself is, how on earth can you even have any confidence that this sort of adjudication even means anything? So bottom line is, it looks like for the first time in a study, we're seeing that we can, with revascularization, maybe reduce MI, but that doesn't translate into a mortality benefit, even when you have extended follow-up. Now, ischemia extent will continue to follow these patients. I believe they have up to 20 years, in fact, follow-up. Now, of course, again, these are now observational. So you're going to see that some of these patients will cross over to the other side. And obviously, optimal medical OMT, or optimized medical therapy, was the same for both groups, so that should not differ. Now, remember we talked about Freedom trial, and we said that CABG has a benefit in terms of mortality and MI, essentially, when you look at them separately over PCI. So CABG, in comparison to PCI, had shown that before. And in fact, in Berry 2D, CABG, in comparison to in a subpopulation of patients, remember the Berry 2D trial was negative with mortality data, but in a subpopulation of the most severe patients in terms of the degree of coronary disease, in subgroup analysis, they had seen some benefit in terms of a reduction of MI. So we do have this idea of reduction of MI. It sounds interesting. It's probably real, but it doesn't translate into a longer life, which is it should. I mean, if top 1 MI, none of them will translate into that. That's something to pay attention to. So maybe you can say, well, if there is some benefit, that benefit seems to be very small if it doesn't translate into any difference in mortality with 8 years follow-up. And of course, we'll see more, hopefully in future, from ischemia extent. Now, we've seen very much similar picture in meta-analysis of essentially trials that looked at revascularization. So this is one published in the European Heart Journal, and looked at 25 randomized trials, about 20,000 patients. As you can see, cardiovascular death and spontaneous MI are reduced based on the meta-analysis when you offer patients revascularization. However, when you look at all-cause mortality, very much similar to what I showed you in ischemia extent. So the relative risk is 0.94, and it crosses 1, barely so, right? So 0.87 to 1.01, with a p-value of 0.11. But nonetheless, now this is all forms of revascularization. So you see Courage here was included in this. You see Berry 2D was included. You see some of other major trials, FAME2, and of course you see ischemia and ischemia CKD included in this. So we've seen this before, I guess, in a way. We are seeing, it looks like we can maybe reduce MI and reduce cardiovascular death, but we haven't been able to quite touch. We're getting close here, right? We're getting close to maybe reduction of mortality. So if you stop here and make a conclusion, you would say, okay, So in select patient populations, maybe, if I offer something like this in 10 years time, I may start to see in a population at the population level some benefit, right? So if you think about any other intervention in medicine, one that comes to mind is essentially glucose control in patients with diabetes and reduction of macrovascular disease. You all remember UKPDS, which essentially did not show any benefit by a tight glucose control in terms of macrovascular complications. But when they essentially followed those patients up to 10 to 15 years, then about 16% relative risk reduction for tight glucose control eventually emerged in an observational basis, arguing that glucose control, obviously we do that for other reasons, mostly for microvascular complications. And there's something for macrovascular complications, but the size of the benefit seems to be pretty small. Now, you may ask yourself, okay, is there a subgroup? Is there something that I can figure out, a subgroup that I can find, it's sort of a sweet spot that I can offer these patients? So one that comes to mind, if you want to think about, is how about diabetic patients? Well, they looked into that. So here's another sub-study of ischemia. And as you can see, if you have diabetes, that's a bad thing, right? So diabetes is essentially associated with adverse outcomes. But how about revascularization? Now, yes, diabetes is bad. That you get more MIs and you die more and so on. But does intervention, revascularization, make a difference? So red is invasive, blue is conservative, and this is y-axis is cumulative event rate. And as you can see, the graphs essentially are superimposed, right? So here's the diabetic population. Of course, the non-diabetic is not surprising. That's what you expected. But even in diabetic population, it doesn't look like that's necessarily the way to go. So anything else? Any other subgroup? Well, you may say, okay, how about I get the most severe patients and I look at them? Maybe that's the group to go for to offer revascularization. Okay, so again, you can see that primary endpoint, and of course, same with some of the essential components of that, MI and all-cause mortality. When you have 3-vessel disease with more than 70% stenosis in all the vessels, or 2-vessel with more than 70% and proximal LAD, so this essentially would be the most severe category of all. And as you can see, it's a bad thing to have more severe disease. That's expected. The more atherosclerosis you have, the higher your chance of having adverse outcomes, heart attacks and death. But does revascularization change this in favor of reducing that? And let's go over that. So here's 1, 2, and 3 vessel disease, right? And as you can see, this is 1. And on this side, it favors invasive strategy. And on this side, it favors conservative strategy. It just smacked right in the center, as if no difference between 1, 2, and 3 vessel disease. How about if you look at the degree of ischemia? I mean, that's, we've always found this very difficult to believe, but here's the data, right? So mild, moderate, severe ischemia, no difference. So it doesn't look like, and of course, the LAD disease, the widowmaker, as we talked about, we said 47% of patients had the widowmaker, right? It doesn't make any difference whether you offer them invasive or conservative strategy in terms of the primary outcome. And this is the primary outcome. So diabetes is not the subgroup, more severe 3-vessel disease or more severe ischemia. No, that's not the subgroup. And this is, by the way, is not surprising. This is courage and shows you exact same thing. Now, this Jeopardy score is essentially a score of the severity of coronary artery disease, and the higher means essentially more severe disease. And as you can see, no difference. And of course, 1, 2, and 3 vessel disease here in a Courage trial showed you exact same. It's sort of ischemia was essentially deja vu. We've seen that in Courage trial also. Again, another analysis from Courage and Berry 2D with LAD showed us the same thing.
Here is another trial. Stitch trial was also a study that looked at medical treatment versus CABG. And I want you to just focus on this graph on the right-hand side and look at essentially patients who had ischemia and were randomized to medical therapy versus CABG. And as you can see, it looks like presence of ischemia, even when you offer CABG, does not seem to make a difference, right? So ischemia doesn't do it, diabetes doesn't do it. And here's an observation study that maybe puts it all of this together. So let me go over this. So this is essentially a cohort of patients that underwent CT. And when they looked at the coronary artery calcium score, and as you know, the higher means the more burden of atherosclerosis you have. And when they looked at a burden of atherosclerosis defined by CAC here versus burden of coronary artery disease or obstructive coronary artery disease, so blue versus this sort of orange-red, as you can see, as you get more burden of atherosclerosis and more coronary disease, non-obstructive 1, 2, and 3 vessel, and of course, as you see more burden of atherosclerosis, you end up having more bad outcomes. That part is not surprising. But when they classified patients based on the burden of atherosclerosis, using CAC in this multivariable model, there was nothing really left for obstructive coronary disease to independently purport essentially adverse outcomes. So what this is suggesting is how it's been very nicely depicted here. When you have similar equal burden of atherosclerosis, it doesn't matter as much if it is non-obstructive or it's obstructive. Okay, so let me take a minute to just dwell on this item. What I'm saying is, it looks like the most important factor is the burden of atherosclerosis and not how many obstructive vessels you have. So you may have significant burden of atherosclerosis, but no obstructive disease. So in other words, you have a CAC more than 1,000, but none of your 3 vessels have any visible obstructions. A significant amount of atherosclerosis, but not necessarily obstructive. We see this all the time, right? And so how do you reconcile this with what I showed you about? It looks like maybe we're getting more MIs, or we prevent more MIs when we, when we offer patients invasive strategy. By the way, just to point out, based on what I showed you, what we're saying is atherosclerosis is a systemic disease, and a focal local solution such as PCI seems to be the best strategy for a focal local problem such as acute MI, when you have plaque rupture and thrombus in a particular lesion that you can go and open up. But when you're looking at patients with stable disease and you're having a systemic disease to deal with, you need systemic treatment options, which is optimal medical therapy, right? Okay, so, but I want to try to see if I can reconcile what I showed you that, okay, it looks like maybe when we revascularize, we can reduce MI, but at the same time, what we're saying is that's not the most important factor. Don't forget the big picture. Big picture is atherosclerosis is a systemic disease and needs to be treated medically. Okay, so here's some very old data. This is from the time when coronary CT was not really a thing. They looked at patients who essentially, presented with MI. These patients were had done coronary angiography 6 months, a year, 18 months before that incident MI. So they knew their anatomy a few months, maybe a year or 2 beforehand. And of course, they came with another MI, right? So they looked at that, at their anatomy and see where was the new MI and how did it look on their previous presentation. And what they noticed was almost 70% of them had non-obstructive disease, less than 50%. And of course, more than 50% is considered obstructive in most studies. Some studies use 70%, but a lot of studies have used more than 50% in our literature. So this study became very famous. People said, remember that most of the MIs happen in essentially non-obstructive plaques. But of course, these patients had an angiogram, a 6 month, a year beforehand. Here's another study that essentially showed us the same thing. So these patients came in, about 697 patients came with ACS. Now they underwent a coronary angiography, and they also had intravascular ultrasound in all of their 3 vessels. And then they were followed until for 3 years. And some of them obviously came back with another MI and had another angiogram. So what they showed us was, so this is TIN-cap fibroatheroma. If you have that, that increases the risk of having major adverse cardiovascular events, right? But if you have that, you have this TIN-cap atheroma plus minimum lumen diameter. So think about it as an index of stenosis, less than 4. It's even worse. And if you have the plaque plus, this is the plaque burden, more than 70%, that's even worse. And then if you have all of them, you have a significant risk of having major cardiovascular events. So there is a way, there seems to be, that we may be able to find some of these patients, maybe, hypothesizing. And CT studies show this even better, that as opposed to what initially we thought, in fact, it looks like stenosis matters. It increases the risk of MI, which we sort of saw in ischemia. Remember, it looks like when we revascularized them, we reduced MI. Even though, again, the big picture is atherosclerosis is a systemic disease. And of course, there's these other sort of parameters that I'm not going to dwell on today about high-risk plaque features. And so, with all of this, maybe there's a way to find some of these patients. Is there a way to maybe come up with a strategy based on CT scan to essentially find some subpopulation of patients that we can offer something like this, offer revascularization? Okay, so let me get you through another study that may shed some light on this. So here's a trial called Complete Trial. Now, these patients, these are not stable patients, 4,000 patients with STEMI. They came in, and the paradigm we've had for many, many years was when you come in with a STEMI, you go in and take care of the lesion that's causing STEMI, and you treat everything else medically. Of course, we always thought that this gotta be, we've looked at, Courage and Berry 2D, all of these trials, this must be the way to go. Of course, some very, very smart people said, well, no, you don't really know that. How about we do a study and look at, these patients and see what happens if we offer either just culprit lesion PCI, or we're going to go in and fix everything that's more than 50% in the context of some, an acute STEMI. The primary endpoint was cardiovascular death or MI. They had a co-primary endpoint, but I'm going to just quickly go over the results. So very, very surprised. Of course, by this time, this was the very first one that actually looked at this. Issue was a trial called PRAMI trial in 2014. So this is published complete in 2019. So we expected that. We have 4 trials that essentially have all of them shown the same picture, that when you come with a STEMI, and let's say you have an LAD lesion, but you also have 2 other obstructive lesions that are not really the ones that are having MI. But if you go and fix those, the patient does better in terms of death and MI when you follow them up to 5 years, right? Now, that's very important. What we're saying is, if I did the same thing in stable disease, it won't make a difference. But then I'm going to go ahead and do this in somebody who comes in with STEMI on non-culprit lesions, and now I can actually make a difference. So what this argues, if I put this together with what I showed you from that CT study and sort of plaque characterization stuff that is a very, very deep literature that I have no expertise on, it looks like CT is helpful or some sort of plaque characterization is helpful, but there must be something else. Maybe that something else is in the blood. So here's one example of that. What's the difference between this patient and a patient with stable disease? The milieu is the difference, right? The setting is the difference. So maybe there's some sort of inflammatory condition, systemic inflammatory condition is going on in the context of an acute MI that makes those other obstructive plaques prone to rupture, which after, who knows, 6 weeks, maybe 3 months, turns into a sort of stable milieu in which, the focus has to be on the global process of atherosclerosis and not necessarily obstructive plaque. So maybe in future, we're going to be able to come up with some idea and find a patient population based on plaque characterization. It's going to be CT, given the availability and the ease of use, but we need something else also. So we need some sort of maybe blood biomarker, and maybe you put all of that together in an AI model. Who knows? AI has become such popular, essentially, approach in medicine, and especially in cardiology in the last a few years. So maybe at some stage we are going to be able to find that subpopulation of patients with stable disease that are at risk of developing MI. Sort of, this is not exactly, of course, complete trial is not exactly that. It's in the context of STEMI, but we're talking about revascularization of non-culprit lesions. But it just maybe shows us that maybe this is going to be doable in future. And this is the holy grail in cardiology. I can tell you that interventional cardiologists are not going to give up on revascularization that easily. So hopefully this is going to be the impetus for us to find that holy grail of what we call vulnerable plaque. That's people have worked on this, people have spent their careers on this. So far, we've made a lot of progress, but we haven't been able to change outcomes, and maybe that will happen in future. So here's the what they did, by the way, in a sub-study of complete trial. They did another form of intracoronary imaging called IVUS, as you can see over here. And what they showed here is that in patients with obstructive, essentially plaque, they had essentially more adverse outcomes. So 47% of patients had an obstructive non-culprit lesion containing essentially these thin capped fibroatheromatous plaques. So these plaques seem to become inflamed or more prone to rupture, and when they're obstructive, they're more so you see about 47% versus 20% obstructive versus non-obstructive. So it looks like an obstructive lesion is just indicating to you that this is a lesion that is more likely to have these higher risk plaques, and this is one that when you fix, you'd be able to reduce outcomes. Now, something that came out of ischemia, which is very important, and I want to point out here is, here's how many patients got coronary angiography on invasive group, almost all of them, versus in a matter of about 4 years, up to about 35% of the patients ended up getting coronary angiography. So what we're saying is, it looks like if we know the anatomy, then we're going to be able to offer these patients a lot less procedures, so to speak, while providing the same quality of care in most patients, until we find out a way of figuring out how to offer patients, how to offer a select population of patients with stable disease, revascularization, so that we can actually reduce MI and reduce mortality, hopefully, moving forward. So everybody, I just want to remind everybody that ischemia was not about patients with acute coronary syndrome, patients who were highly symptomatic, left main disease, and essentially patients who had ejection fraction less than 35%. So in the interest of time, I think I'm going to stop there. There are some more interesting stuff, but I think that I got to the gist of this. So let me go to this clinical vignette and ask you, okay, so the patient that I showed you, what are we going to do with him? Well, So he's diabetic, right? He's 68 years old. He's not sort of the picture of that complete trial. This is stable disease. So our practice today is, despite the fact that with ischemia, we know that we can treat these patients medically. When it comes to diabetes and three vessel disease, we get even more worried about those extra MIs that I showed you. And so these are the patient population that we mostly refer for bypass surgery, even though in select population of them, if somebody says, listen, I really want to avoid surgery and try medical treatment and see what happens, it's an option. It's an option to do that. But most of these patients today still get referred for bypass surgery. I want to point out something that remember that most of the three vessel disease that we send for bypass surgery are in fact the ones who come to the hospital with acute coronary syndrome. Now, I don't want you guys to confuse that with somebody who's picked up off of a stress test like this. If you come in with acute coronary syndrome, go to cath lab, and you have a plaque rupture and three vessel disease, based on that complete trial that I showed you, the treatment of choice, definitive treatment of choice, is revascularization. Okay, I think I'm going to stop there. I wanted to share some of my research, but in the interest of time, I'll stop there and open up the forum for questions.
Thank you, Dr. Ghafghazi. That was very, very illuminating, somewhat confusing. I have to say that even cardiologists are confused. The talk was excellent. And if I say the word confusion, it's not because Dr. Ghafghazi was confusing. He tried to make it as clear as possible, but the field of cardiology is confusing. And even though he mentioned that the NHLBI spent $100 million on ischemia, and after 50 years of treating ischemia every day, we're still scratching our heads as to what's the right strategy. I want to point out a couple of things to the audience. Dr. Ghafghazi has already made this clear. Remember, the trials he mentioned do not include patients with acute coronary syndromes. He emphasized that. So revascularization is required for acute coronary syndromes because there it improves prognosis. Second, this does not include patients with ejection fraction of less than 35%. So if you look at STITCH, there was a mortality benefit in patients with EF that is low. So once the heart is that starved of oxygen, revascularization is the best strategy. There's many other exclusions. Left main disease, they do better with CABG. Microvascular angina that he mentioned, those people shouldn't be ignored. There's no revascularization in them, but they do better with medical therapy. So this is an evolving field. And if somebody, mentions that having an MI is not an insignificant event, and you saw some data showing that invasive management may decrease the risk of MIs, especially as time goes along, that requires a patient-clinician discussion. I think the key point for you to remember is initial medical therapy is not insignificant. If you look at the older trials 40 years ago, people were not even on aspirin. And nowadays, most patients are on aspirin, statins, beta blockers, ACE inhibitors, and those improve prognosis. So that should be the cornerstone of therapy. And then after that, if somebody is still having symptomatic angina, revascularization is perfectly acceptable in the guidelines. So thank you for that fantastic talk. And I think I see some questions coming in. Jason, do you want to take these, or do you want me to do this?
I can read them off for him. There's a couple of, one was from one of our retired researchers, Dr. Stanley Levinson. He said, want to know, are some outcomes due to collateral circulation? And if this plays a role, can you assess collateral circulation?
So yes, you can assess collateral circulation in the cath lab, essentially with coronary angiography. Now, whether collateral circulation necessarily improves outcomes, to the best of my knowledge, you're lucky if you have collateral circulation, but it's hard to compare that or come up or design a study that would compare collateral circulation with lack thereof. It's a matter of how your body reacts to obstructive coronary disease, and if you're lucky and you're able to grow new vessels, essentially, which is collateral circulation, then you probably do better than if your body doesn't do that. Jason, you're mute.
Jason, I think you're on mute.
Thank you. Sorry about that. It's from Dr. Ashutosh Barve and GI wants to know how many people in the ischemia trial conservative treatment arm crossed over to get revascularization therapy.
So let me quickly see if I'm still sharing. I don't believe I am. So about 30% of patients essentially crossed over to revascularization arm in ischemia, about 30%. And it was not much necessarily different between, in fact, the Coronary trial and very 2D. So about 30% by the time the initial study was finished, crossed over to invasive strategy. So not a significant number of patients for sure. Again, you're on mute, Jason.
Jason, I think you're you went on mute again.
Yeah, I apologize. We have a group of yapping dogs here, so I just want to make sure I'm not that's not going out. No, I was going to say if anybody we just got real quick. If anybody had we got maybe a minute. If anybody had any last second question, you can unmute and ask, or if you want to post in the chat area. Now, Dr. Ghafghazi, I don't know what happened. You're got a little muffled there. I don't know if your microphone got something, but yeah, it sounded like it seemed when we got to the Q&A, it seemed like your sound kind of.
No, can you guys hear me now?
Yeah, we can hear you.
Okay.
Yeah.
All right. Well, if nobody has anything, I want to thank you again, Dr. Ghafghazi and Dr. Kalra for helping facilitate and a great presentation. And we will see everybody in a couple of weeks. And I hope everybody has a great Thanksgiving holiday or great, next week. And we'll talk to everybody soon. And thank you again. And is there anything you'd like to wrap up with, Dr. Kalra or Dr. Ghafghazi?
Thank you.
Thank you.
All right. Thanks, guys. Dr. Ghafghazi, what we're going to do is